In this video, we demonstrate the collection of respiratory specimens from children for TB investigation. Infection prevention and control before and during the collection of all respiratory specimens. Before the procedure, procedures should be conducted in dedicated cough rooms, extracting air at 6 to 12 air exchanges per hour. Alternatively, well-ventilated rooms with air exhausting to the outside can be used. Hands should be washed with soap and water before and after procedures. All surfaces should be cleaned with 70% alcohol or hibitane solution before and after each procedure. All staff must wear personal protective equipment, including particulate respirator masks, gloves, and plastic aprons. Caregivers assisting should also be given particulate respirators to wear. The door should be locked or a sign be put up outside the door indicating that the room is being used for sputum collection. Gastric aspiration. Equipment required for gastric aspiration: a nasogastric tube, 6 to 10 French to fit the size of the child, sputum specimen container, screw top, preferably falcon tube, 5, 10 and 20 ml syringes, litmus paper or pH strips, 4% sodium bicarbonate solution for bedside neutralization, oxymetazoline nose drops, local anesthetic gel, laboratory bags and laboratory forms, 3 bed sheets or surgical drapes, 1 for the bed, 1 for wrapping the child into, and 1 for putting over the child, and normal saline or sterile water in single-use vials as standby for gastric lavage if necessary. Performing gastric aspiration. This procedure is routinely performed by the study nurse or ward nursing staff. Check that the child has been fasted for a minimum of 4 hours. Have an assistant help, as this procedure requires 2 to 3 people. Prepare all the equipment for the procedure. Place a drape over the bed, 1 drape to immobilize the child, and 1 to cover the child, leaving the head exposed. Position the child in decubitus supine position with the help of an assistant. You may instill 2 drops of oxymetazoline into each nostril to induce vasoconstriction and prevent epistaxis. Measure the distance of the nasogastric tube to the stomach, from tragus of the ear to the nose to the xiphisternum. This estimates the distance that will be required to insert the tube. Coat the outside of the nasogastric tube with local anesthetic gel. Placing the child's face in the sniffing air position, a nasogastric tube is passed from the nose into the stomach to aspirate gastric contents. Attach a 20 or 10 ml syringe to the nasogastric tube. Withdraw gastric contents using the syringe attached to the nasogastric tube. Check the nasogastric tube position by pushing some air from the syringe into the stomach and listening with a stethoscope over the stomach, or by checking the pH of the aspirate. Aspirate stomach contents gently and steadily, with the child in each of 3 positions: head central, left lateral, and right lateral. Allow a few seconds before aspirating after changing position. If no fluid is aspirated, push the tube 1 to 2 centimeters deeper or pull out 1 to 2 centimeters shallower and aspirate. Any volume more than 1 ml is adequate for bacteriological examination. However, attempt to obtain as high a volume as possible, aiming for a minimum of 5 ml, especially from a sick child where a diagnosis is more important. Transfer the full volume of gastric fluid from the syringe into a sterile container. Determine the pH of the gastric aspirate. In this case, the pH is between 3 and 4. If the pH of the aspirate is acidic, titrate the volume of 4% sodium bicarbonate using a pipette or syringe and pH strips, adding small amounts to the specimen until a pH of 6 to 7 is reached, in order to neutralize the acidic gastric contents and so prevent destruction of tubercle bacilli. Ensure adequate mixing of the bicarb with the aspirate after each addition. If the pH of the gastric aspirate is more than 6.5, no bicarb is required. In this case, the final pH achieved is approximately 7. Clean the outside of the falcon tube with alcohol swabs. Label the sample, including sample type and number, the date, time of neutralization, volume of bicarb added, and total sample volume. Infection control measures to be followed after procedures. Samples. Specimen containers should be closed tightly and the outside of the container should be disinfected before it is labeled. The sample is then placed in a sample bag. All specimen bags should be placed in a cold box as soon as possible after collection for transport to the laboratory. The cold box should maintain a temperature of 2 to 8 degrees Celsius. Equipment. Discard any disposable equipment, including nebulization masks and suction tubing, into a plastic bag. Discard gloves and disposable aprons, as well as the plastic bag, into a biosafety bin. Hands must be disinfected immediately. Reusable aprons must be thoroughly disinfected after every procedure. The room. A minimum of 20 minutes should elapse between patients brought into the room for procedures if extracting air at 12 air exchanges per hour. If using a well-ventilated room, allow 30 to 40 minutes between procedures. Wait at least 10 minutes before exiting the room. Close the door immediately. Indicate the time when the next procedure can be done on the fake clock on the door. Nasopharyngeal aspiration. The equipment required for nasopharyngeal aspiration includes suction apparatus, including a suction machine and suction tubing, sterile 6, 7 or 8 gauge mucus extractors, oxymetazoline nose drops, normal saline in 5 to 10 milliliter vials, cotton wool, paper towels, a kidney dish, laboratory forms and laboratory bags. Follow infection prevention and control procedures as noted for gastric aspiration. Check that the child was fasted for a minimum of 2 hours. The child's nose is cleaned with saline drops and cotton wool. If old enough, the child can be asked to blow the nose into a tissue. If the nasal mucus is too thick to be removed with the measures above, it can be suctioned prior to nasopharyngeal aspiration. A soft catheter size 6 or 7 is used for suctioning and is discarded immediately afterwards. One drop of oxymetazoline may be instilled into each nostril to prevent nosebleeds. A few drops of sterile saline are instilled into each nostril. The length of the cannula used for aspirating the nasopharyngeal sample is measured as the distance from the nostril to the tragus of the ear. The posterior nasopharynx is then suctioned using a soft plastic cannula connected to the mucus trap. Suctioning is activated only when the tip of the cannula is in the posterior nasopharynx. When the cannula is passed through the nostrils during introduction and extraction, the suction is deactivated. Repeat infection control procedures after the procedure, as noted for gastric aspiration. Sputum induction. The equipment required for sputum induction includes salbutamol metered dose inhaler, a spacer with face mask, suction apparatus, a pulse oximeter, a nebulizer with tubing and face mask, hypertonic 3 to 5% saline solution drawn up into a 5 ml syringe, 5 and 10 ml syringes, sterile 6, 7 or 8 gauge mucus extractor, sputum specimen container screw top for older children who can expectorate, paper towels, laboratory forms and laboratory bags. Follow infection prevention and control procedures as previously noted. Check if the child was fasted for at least 2 hours. Assess the child's clinical condition and record your findings in a clinical evaluation form. Check carefully if any contraindication for sputum induction exists. If in doubt, discuss with a clinician. Oxygen saturation and pulse rate must be monitored throughout the procedure. Stop the procedure in event of a fall in saturation to less than 90% and a pulse rate more than 180 or less than 100 beats per minute. The child is pre-treated with 200 micrograms of salbutamol via metered dose inhaler with attached spacer to prevent bronchoconstriction. This is done by placing the assembled metered dose inhaler, spacer and mask onto the child's mouth and nose. The child is allowed to settle until breathing freely. 1 puff is activated, keeping the mask in the same position, and the child is allowed to breathe 4 to 5 times. The mask is then removed. The child's nose is cleaned with saline and cotton wool to remove nasal mucus prior to sputum induction. If nasal secretions are thick, a soft catheter size French 6 or 7 is used for suctioning and is discarded immediately afterwards. A jet nebulizer attached to oxygen at a flow rate of 5 to 7 liters per minute delivers 5 ml of 5% sterile saline for 15 minutes or until the child starts to cough. In young children who cannot expectorate spontaneously, once the child starts to cough, sputum is obtained by suctioning through the nasopharynx with a sterile mucus extractor. Pass the catheter up to a length equal to the distance from nostril to tragus of the ear without applying suction. Once in position, apply suction. The catheter can be moved a little and turned to facilitate the cough reflex and aspiration of sputum. Once sputum is obtained, the catheter is withdrawn from the nose. Do not aspirate as the catheter passes through the nose. If the child does not cough after nebulization, chest percussion is done over the anterior and posterior chest wall. Mucus is then extracted as above. Nebulization and chest percussion followed by nasopharyngeal aspiration can be repeated if an inadequate sample is obtained, any volume less than 1 milliliter. In older children who can expectorate spontaneously, once the child starts to cough after nebulization, encourage the expectoration of sputum into a sputum container. The child should continue to expectorate until no more sputum can be produced. Nebulization can be repeated if an inadequate sample is obtained, a volume of less than 1 milliliter or a watery sample indicative of saliva. If the child does not cough after nebulization, encourage the child to perform deep breathing. The child can also be made to jump or run on the spot if clinically stable and able to do so. Chest percussion is done over the anterior and posterior chest wall. Encourage the child to expectorate as above. The specimens will then be transported directly to the laboratory for processing. Spacers and nebulizer equipment will be sterilized after use in every patient. Complete the clinical evaluation form after the procedure. Any new signs of respiratory distress not settling after 5 to 10 minutes of supplemental oxygen via face mask must be reported immediately to the attending clinician. An adverse event form must then be completed. Repeat infection control procedures as previously noted. Contraindications and precautions for sputum induction. As hypertonic saline causes bronchoconstriction, the procedure should only be performed after pre-medication with salbutamol and under medical supervision in patients with asthma or severely impaired lung function. As the procedure induces coughing, it should not be performed in patients in whom severe coughing may be harmful, including patients with unstable respiratory state, such as acute respiratory distress, pertussis syndrome, hypoxia, and pneumothorax, unstable cardiovascular status, including untreated cyanotic heart disease, recent surgery, any condition where the patient is unable to protect the airway, for example, a depressed level of consciousness.